Everyone, Dr. Dobson here. First of all, just wanted to say sorry for the delay in uploads. We're going to go over a case today, 1.5 Endo and build-up restoration. I posted the case on my Patreon. If anybody wants to see it without any fast-forwarding or scrubbing. So that's already up there, as well as an implant case and a clinic tour. And I'll post the Patreon link in the description if anybody wants to see it. So getting into the case, this is a patient that we saw for the first time that made an appointment for a severe toothache that he had in the upper right. So we took an x-ray and we can see that it's the 1.5 that's responsible. Irreversible pulpitis was a diagnosis because of spontaneous pain without stimulus and severe pain to stimulus. So we made the plan to do an emergency root canal and build up. So some photos. Here's some caries reduction. There's after the prep. This is the tooth. You can see it's vital, the pulp there. After the prep, we found 2 canals. We obturated them with single cone bioceramic sealer, and then we built it up with Aqua Forte, of course. So here is some footage that we're gonna show. Here's just instrumenting the canals and then obturating, filling up with Aqua Forte. So he also had a tooth on the left side that had a big cavity in it, but he did not report any symptoms coming from this one, and it tested normal to pulp testing. So we actually just made the plan to do a DO on this tooth that I'll be showing as well closer to the end of the video. And that one, to my knowledge, is doing well. This is the first time that we had ever seen this patient and the last time, so I imagine that he's doing okay. But that's what we did. So 1.5 Endo, 2.5 DO. Here's where we ended up. The 2.5 DO and the 1.5 Endo. Let's see here. Yeah, 1.5 Endo build up. Advised a crown, but we haven't seen him since this appointment. So who knows how it's doing. Got a little sealer puff there, so we'll get into the footage here. So first order of business is going to be doing our access prep and our gross caries reduction. We know that it's going to be a massive lesion, so we can pretty generously extend our outline form initially with our KS1 on a high-speed handpiece. And these are air-driven hand pieces that I use, but actually I've just recently put in an order for electrics. This is a photo that I forgot to zoom out of just initial sort of caries reduction. Once we have some access, then we're going to go in with our slow speeds and just start removing soft tooth structure until we are back on healthy dentin, and we're going to use tactile pressure to determine where our healthy tooth is. And of course, being more aggressive around the DEJ to ensure that DEJ is cleaned of any caries thoroughly. So we'll go back and forth between the slow speed and the high speed, refining the prep and removing decay until we're satisfied. Basically going to have the prep finished before we start doing the endo, so that once we finish our endo, we can just put a matrix on it and restore it. And once we can see our canals, then we'll put a rubber dam on and then start doing our endo. Maybe doing a little bit more prep refinement. Just nice to work with the rubber dam to separate the tooth from the mouth. I find that it just kind of depersonalizes the experience. It's just kind of like working on a typodont, because all we can see through the loupes is just the teeth, and it's nice to not have soft tissue and tongues to have to deal with. So we froze with Articaine, but of course, as the tooth is vital and hot, he is going to feel some pain, 2 out of 10, 3 out of 10 kind of thing as soon as we're accessing the pulp chamber. So we will go in and give some intrapulpal anesthesia once we have punched through the roof of the pulp chamber. And once we've done that, then we'll go in and unroof the pulp chamber. So we're going to do that with our large Muntz Discovery burr here. These burrs come in a pack of 6. from large to super tiny. And I find I pretty much just use the large one and the second smallest or third smallest. So we unroof the pulp chamber, and we pretty clearly see that there's going to be two canals. There's two orifices, and we're just going to put some articaine in both those orifices before proceeding with preparation. And just refining the tooth a little bit more so that we are happy with our prep. We make an occlusal dovetail just like we always do for class 2s. I think that class 2 restorations without dovetails are a bad idea. So we'll just fast forward until we get to the preparation part of the procedure. Slow speed, cleaning out the DEJ, everything out so that we can restore once the endo's finished. So there is pretty much going to be about right. So, and actually, instead of using liquid dam in this situation, we just ended up putting on a sectional matrix to isolate the tooth so that our hypochlorite doesn't spill out. So put a separator on just to kind of get the ligament stretched out. There's a photo of the situation right before we begin prepping. Vital tooth and two canals, though it is a 5, a second premolar. You know, whatever it is, two canals in 30% of cases or so. I don't know the number, but we'll go in with our file sequence, SX. SX file, take that down 10 millimeters or so, and then go to our next file, which is a S1 1504, and we're just going to take that down. We're going to clip the apex locator to the file. You can see there, it works great. No need to take working length radiographs in most cases if the apex locator is doing its job. And we'll take our F1 down to length. And I think we actually skipped glide path file because this was a 30-some-year-old patient, and the canals were wide open, so there's no need to use a glide path file. And we'll get most of the pulp out with our 1504, and then we're actually going to skip a 2504 and go to a 2506. Which is the next file in the sequence that I use. So we'll take that down to length to the green line, and then we'll use our 3504, which is going to be our last file, and then we'll be ready to do a final irrigation and activation with the endo activator. I think we actually took we did take a cone fit x-ray in this case just to verify, which I'll do 50-80% of cases or so. Gonna irrigate again and then be ready to obturate. Bad form, by the way, I realize the matrix band came off. Should have used liquid dam there, I acknowledge. So we're gonna shake the irrigant thoroughly in both canals, and then rinse one more time before drying and filling. So taking our full strength hypo, there's the tooth with both canals fully prepared. We're gonna dry, decided to use F3s this time. And then we're going to fill, and we have some seepage from the gingiva coming in, which is bad form. Again, I'll acknowledge for sure. But I'm not sure if it has an impact on outcome, but we're going to fill the canals up with bioceramic sealer and then put our cones in, snip, and then I'm just going to whack them down with a burr in this case. And then use a slow speed to take them down to the orifice, and then we'll be ready to restore. So there's the tooth after it's been filled in. And then we'll put our matrix band. I don't know why I took it away during the preparation and irrigating, but take our separator ring, put it on, sectional, burnish the matrix, and then we'll be ready to fill it up with Aqua Forte. So that's ready to go. We're going to condition it with 5-second phosphoric acid. Throw a rinse. There it is after conditioning and ready to restore. Take our Aqua Forte, fill it up all the way. And then I like to pack the material in with a moist cotton pellet. I forgot to zoom out of that one, but that just showed the final endo. I think they merged about 5 millimeters before the apex. And then gonna reduce our excess restorative material and take our sectional off. We wait 5 minutes, 5-6 minutes for the material to set. These large class 2s, sometimes it's better to wait 7 minutes, 8 minutes before taking off the sectional matrix. And we're going to check the bite, reduce any high spots. And then we're going to get moving to the 2.5 where we did just the selective caries removal and a DO restoration on the very deep lesion that tooth had. That was heading to the direction of this one and may still need endo. Actually, we advise the patient that deep cavity, decent chance that symptoms may develop. But like I say, we saw this guy once and never again. So be interesting to give a follow-up phone call and see how the teeth are doing. Going to put our Equia coat, sealer, varnish on, light cure it, and then check the floss. There's the final restoration. This tooth is good to go. So we're going to freeze the 2.5 and then get a rubber dam on. This is how the 2.5 looked clinically. And so we're going to start doing our prep, aggressive outline form. We know since it's going to be a deep lesion, it's going to open the contacts with our KS1 and then start removing decay with our slow speed. And we're going to be careful to only remove decay around the DEJ and not go too deep pulpily, because we want to leave some infected, whatever you want to call it, dentin at the pulpal floor and seal it off with our restoration so that it does not progress towards the pulp. I'm going to use a flame to remove any sharp corners from our prep. And then I think this is pretty much the final prep. There's some blood covering the DEJ there, but it's all cleared out. A little bit of debris here, but we have a clean DEJ, and that's what we want. We can leave that last little bit at the pulpal floor. That's just going to get sealed in, and literature shows that decay does not progress if there's a good seal, and I don't think that there's any better seal than a glass-based restoration like Aqua Forte, because it doesn't shrink, whereas composite does. So, because it's chemical cure, not light cure. Light cure things will shrink, even if they're bulk fill. So we finished our prep for the 2.5 DO, and we're going to put a matrix band in, and I like to kind of apply apical pressure and then wiggle the wedge in and out, and you'll really feel it go down into the sulcus more that way. And then we'll put our separator ring on, and a way that I like to get tight contacts once the separator ring is on is to kind of give it a squeeze and a shake to kind of force the teeth apart as much as possible before burnishing and then restoring. Sometimes you can even leave these things on for doing a recall and then be absolutely sure you've got good contact. So we'll burnish the matrix against the neighboring tooth, the 2.6, and then we'll restore. This is the tooth ready to restore. So you can see the DEJ is cleared out. A little bit of blushing at the pulpal floor, and tell the patient that, you know, it's 50-50 as to whether or not it's going to need endo in the short-term future or longer-term future. Just going to clean out one last little bit with the matrix on, and then condition with phosphoric acid quick, and then apply our Aqua Forte. And it's easy to get air bubbles actually with Aqua Forte. If you take an x-ray of these things sometimes, you'll see the non-homogeneous appearance. So application technique is important to kind of put it close to the bottom of the prep, but not touching the bottom of the prep. And then I find expressing it a little bit quicker can help with the kind of flowability so that it adapts to all of the prep walls. And then packing with a cotton pellet helps as well. There's the tooth after it has been, after we've filled it up with Aqua Forte. And then we'll just, oh shit. I guess I didn't record the finishing of that tooth, but that's that one there.